In the second part of the lecture, I want to examine the rise of medical sociology as a subfield of sociology and examine its key contributions. Sociology of medicine, or as it is also alternatively called medical sociology, is one of the largest subfields in sociology. It explores a long list of healthcare issues, including the physician patient relationship, illness behavior, stress and coping, healthcare policy, and public health. It also has drawn on and made excellent use of a wide range of sociological theory, including structural functionalism, symbolic interactionism, feminism, and postmodernism. It has also intersected with a variety of other social sciences, namely medical anthropology and epidemiology, to produce important research that has helped to improve the practice of medicine and the health and well being of people worldwide. There are three important points to take away from Phil Brown's reading in Unit 1, Themes of Medical Sociology, regarding the role of medical sociology in, in the greater field of sociology. The first is that medical sociology centers on the social construction of health and illness. A construction, he argues, that is shaped by the many elements of the social order and often independent from biomedical phenomenon. And the social construction of health and illness is something that we're going to get into a little bit in in the third part of this lecture, but more so in module number 2. Secondly, by making use of the social constructionist perspective, medical sociologists are able to relate and understand health and illness in many different ways. For instance, at the very basic individual level, in creating self-awareness, what is considered the micro level. Secondly, individual action and interactive communication in the spheres of hospitals and medical education, also called the meso level. And lastly, at the national level, the country's standing in health aspects, healthcare systems, and their political economy and national health policies. This is the macro level. The last key theme in the Phil Brown reading in Unit 1 is that medical sociology is really concerned with the distinction between disease and illness. Even though disease is a biomedical phenomenon, it is also shaped by social forces. Because medical sociologists have helped us understand that illness is a social construction, a phenomenon caused by human institutional beliefs and actions rather as solely by value-neutral physiological processes, we can examine the historical development of, let's say, disease rates. For example, we have learned that morbidity and mortality for the acute diseases have been affected by public health measures, for example, sewers, access to clean water, and overall economic development, such as the case of nutrition, rather than only medical treatments. So when we look at infant mortality rates, we see that life expectancy at birth among indigenous Australians is substantially lower than that of non-indigenous Australians. The global context affects how societies prosper through its impact on international relations and domestic norms and policies. These in turn shape the way society, both at national and local level, organizes its affairs, giving rise to forms of social position and hierarchy whereby populations are organized according to income, education, occupation, gender, race, ethnicity, and other factors. Where people are in the social hierarchy affects the conditions in which they grow, learn, live, work, and age, as well as their vulnerability to ill health and consequences of ill health. Medical sociology can be traced back to the late 1800s. It was in the latter half of the 19th century that sociology and allopathic medicine, or conventional medicine, here conceptualized very differently from homeopathic medicine, began to cross paths in different ways. For medicine, this time witnessed the beginning of its consolidation as a profession, and it was granted legitimacy and social power. At the same time, sociology was also beginning to emerge as a distinct discipline. The first sociology course was being taught at the University of Kansas in 1890, and the first department of sociology was also founded at the University of Chicago in 1892 by Albion Small, who 3 years later would also launch the first sociology journal, American Journal of Sociology. The field of medical sociology underwent an explosive period of growth before peaking in the early 1970s. The next decades had great implications for the future of medicine due to the rise of managed care and the commodification of medical services, among other factors. The discipline's theoretical and conceptual framework initially came from Talcott Parsons' chapter in the book Social System, entitled Social Structure and Dynamic Process, the Case of Modern Medical Practice, where he drew on core aspects of sociological theory, such as the sociology of deviance, among others, to reframe issues of health and illness from a functionalist perspective. It was these early sociologists that argued that the new field that was being shaped, called medical sociology, must involve the application of sociological knowledge and concepts to issues of health and illness. It is distinct in its approach because it considers the import of these social and structural factors and the effect that they have on disease and illness, as well as on the organization and delivery of healthcare. This includes factors such as culture, organizational processes, such as bureaucracy of hospitals, politics, economics, as well as socialization and group processes. So, what are some of the things that medical sociologists do and do not do, according to Phil Brown's theme in medical sociology? I have isolated 6 key issues to medical sociologists. The first is that medical sociologists do not doubt the significance of the advances in medical technology, diagnosis, and treatment. Yet, they call attention to the overuses of surgery, where not necessary, and also key abuses of medical technology and experimentation. Secondly, medical sociologists emphasize the role of social structural factors, such as race, class, gender, sexuality, and the effect that they have on epidemiology. Questions that medical sociologists will ask is, how do structural issues such as these affect illness, behavior, experiences of illness, and personal experiences with ill health? Whereas medical model attempts to separate body and mind, medical sociology brings them together. This is important in terms of fostering social ties to help cope with emotions, stress that may arise from an illness or disease. For example, it has been shown that cancer survival rates are affected by social networks and emotional responses. Fourthly, medical sociologists examine the healthcare system, its rise, and the current ways it's operating in terms of managed care. This is a very important issue, as we're going to see, as terms such as Obamacare are kind of being thrown around, and there's a lot of confusion amongst the public regarding how healthcare is being managed in the country and the costs associated with healthcare. The fifth thing that medical sociologists engage in is that they raise ethical questions regarding the profession and institutional controls over life, health, and well-being. And we're going to see this furthermore when we examine a classical study in bioethics, that of the Tuskegee Institute study. Lastly, medical sociologists examine how medical knowledge about a disease or illness are produced. Under which condition does a set of symptoms become an illness or disease? And this is more discussed in the reading for Unit 2, which we'll return to now.